Just out of curiosity, what are your thoughts when people are suggesting they're going to stop Revlimid maintenance at that 18-month mark?
I'm still not favoring. I still say, I think we have to keep in mind we have survival data. So the meta-analysis shows survival benefit, 7 years overall survival benefit for patient on LAN maintenance versus placebo is a piece of data we have to obviously discuss. It's different if patient is struggling because, the count, because diarrhea, so side effect, then they know that you can reuse the Revlimid, for example, with the DARA when they progress. That is a different conversation, but I do like hearing that this is something that people thinking to do, just give a short course of maintenance because then you have your LAN as a best partner for the DARA. Because I don't think we have to ignore the survival benefit that LAN the concept of maintenance on the multiple clones, so the continuous therapy can give us. But again,
I agree. I think I would echo your points. First, you have to make the maintenance acceptable, and I've been to venues where the participants are pushing the dose to the misery of the patients, and I am reassured by the data that in Canada, where we tend to give lower doses, and the data from Princess Margaret, where we certainly documented much lower doses, and we got the same benefit. So I think we're very aware of toxicity, and you have to make it acceptable to the patient so we don't use as big a doses. That's the first thing. And I'm intrigued, although it's preliminary, by the British data that you may keep the clone quiet and get less mutations rather than stopping effective treatment because of that concern that what kills a lot of our patients. It's when the disease becomes so aggressive, it's acquired all sorts of new mutations, and it doesn't look like myeloma anymore. It's extramedullary and nothing controls it. And if we can prevent that very aggressive phase, I mean, this hasn't been tested, but if we can stop the mutations, keep it quiet, not let the foot off the gas pedal of suppression, then maybe that's helping change the natural history of the disease. So,
yeah, it seems to me, a couple of the concepts that we've talked about here tonight, so that clonal tiding, that continuous therapy, suppressing that clone, and then taking your best treatment and using up front. And don't shortchange patients and think you're going to stop that frontline treatment. So truly, induction, transplant, and maintenance goes on. And if you shortchange people in the maintenance phase thinking you're going to save something for second line, we all know there's a certain percentage of patients who aren't going to get there. So you're probably doing them a disservice by thinking that you're saving something, and some of those patients aren't going to benefit.
So we don't do that in other cancers, and I think the only reason we've considered it is our funding and the order in which the trials were done. And this isn't a position that we'd want to be in indefinitely in an oncology field. Unfortunately, I don't think we'll have to. It'll be a few years, but eventually we'll be using DARE up front and using it with the IMiDs up front, and then I think there'll be another quantum leap in outcomes like we saw when IMiDs were first introduced.
I agree, and I think another reason not to stop maintenance early is what you mentioned earlier, Donna, that the data with DARA plus POM and isatuximab with POM and probably with other agents too looks good, and that's evolving, and we may yet have access to that within several years. For these patients that have very long remissions with Glenn post-transplant.